we will go ahead and get started. Who has questions for the clinicians? And if you don't, then I'll pull, yeah.
Hi. I guess let me start with I only caught part of the ketones presentation, but as a VLCAD patient who also has hypertension, like high blood pressure, would that be something that would be an option or not? Because I don't know, you were talking about sodium and salt, so I was like, oh, maybe that's not something that would be a possible combination or future treatment.
Yeah, so we talked about two different ketone options. There's a ketone ester and there's a sodium or salt ketone. I would say that especially the sodium hydroxybutyrate is probably not a good idea. Ketone esters are, as you mentioned, on the market. You can buy them over the counter, and it's a ketone on a glycerol backbone, and it doesn't have any salt in it. It does have a little bit of a taste like gasoline, so it's not terribly tasty, but it does provide an exogenous ketones, and athletes on the Tour de Force and Tour de France and a bunch of people are using them. So they are available.
And maybe some people are more sensitive to sodium than others with regard to their blood pressure. So if you're one of the sensitive people, you really have to pay attention to it.
And then I just had one other question. This is more on the physical therapy side. So about 5 years ago, I went to my metabolic specialist, and I kind of was asking them about, hey, could I have a PT referral? Because I was having this cycle of, I would be able to exercise and I would build myself up to a point where I felt really good. And I was like, I feel strong and I feel like I can, active. And then I would have kind of cycles of elevated CKs where my activity level obviously had to be much lower. And I would just feel really kind of weak. Right. And I just felt like I was starting over every single time. And I didn't know, I'm definitely not an expert when it comes to exercise and things like that. So I felt like I was having to build myself back up again, but I didn't exactly know how to do that safely in the context of not giving myself higher CKs or rapid. So anyways, I made the suggestion, and they were definitely and again, this was 5 or so years ago now. So hopefully maybe things have progressed past this point, but, they were definitely hesitant. Is there any advice? I think my persistence just eventually got to them, and then they were like, oh, okay, we can do that. Let's it won't hurt. That was kind of their thing, but I had to ask a few times. Do you have any suggestions of just overall kind of things you can tell them about benefits of physical therapy for people with FAODs to kind of maybe encourage that conversation or encourage them to be more, maybe even more proactive about it?
So I've definitely found that certain doctors can get into certain tracks where they don't necessarily think of referring to physical therapy. The thing that pops into my head most recently that I've dealt with is I have a 13-month-old baby on my caseload who had a brachial plexus injury from his positioning when he was born. So his right side looks like this. And mom followed up with an ortho surgeon, and the ortho surgeon showed her how to stretch his arm. So he kind of was like, okay, well, that's it. That's all physical therapy is going to do. But then as he grew, he never learned how to use that arm, and he crawled on this straight arm with this bent wrist. And now he's 13 months. And now we're kind of at the stage of, okay, he can't really pull to stand because he only can use one arm. So mom's persistence helped her get into PT. And I personally have no problem going to bat against some of the ortho surgeons and things like that of talking about, well, here are the things that we're working on. We want to give him active movement. We want to make it functional, because sometimes they just get stuck on what they do, because his response to me was, oh, well, when he gets older, I'll just replace some of his tendons. I was like, well, that's talking at 10 years old. We're at 13 months now. So there's a lot of life that needs to be lived in the interim. So what I would say to you from that is just persistence is definitely key. And sometimes you guys are exposed to different things than some of the docs are. Sometimes they get a little old school or set in their ways. Not all of them. Some of them are really great. There are good ones and not so good ones. It's just a spectrum. I'm hoping more research gets out there talking about different things PT can do with FAODs. The case study that I published a year ago is now out there. So hopefully just as more and more comes out, we can show the evidence that it is helpful and it can show progress and more function.
Yeah, just to preface it, I'm in no way saying they're not bad doctors. They were not. I think part of the issue too is like I think their concern was like finding a PT who like understood rhabdo and even had like an idea of what an FAOD entailed. I think that was part of their concern too.
And that's a great point too, because just like with docs, there are PTs on a spectrum too. I would encourage you to look for PTs who have gone through increased education. So you can tell that by the initials after their names. One thing that I'm looking to pursue in the coming years is my PCS, my Pediatric Certified Specialist. And what that entails is just proof that you've worked a certain number of hours with complex patients in a certain population, you've done research, you've done a whole bunch of different things. You take another 7 or 8 hour board exam to get that specialty. That would be my first go-to, a PT who has a PCS. After that, if no one's available, you could look for a PT who has an OCS, which is an ortho certified specialist, because they should be very familiar with rhabdo and how to help you train and recover and gain more strength in your muscles. If one of those isn't available, my next suggestion would be a CSCS, which is Certified Strength and Conditioning Specialist.
Great, thank you.
So two questions. The first one about rhabdo. We had a lot of talk this weekend about rhabdo and exercise and rhabdo and sports and athletes and things like that, and kind of some guidelines and recommendations for that. But I wonder if you guys have similar recommendations for maybe younger kids who are not at that level of athletics yet, that still get into rhabdo for other reasons. Like my son is 7, but he gets into rhabdo a lot for heat. And, you know, his hospitalization in January is because they were outside for 45 minutes. His teacher forgot to bring his Gatorade out. He only had one of his cups of milk at school, not both, you know, and we ended up in the hospital for a week. You know, that wasn't anything to do with any physical exertion. Like he wasn't running or walking or hiking or anything like that. And even after that, we realized that we had to slowly integrate him back into the class. Like his teachers were saying that he was really sleepy in the morning still. And so we kind of did a half day, kind of back like for a week, did half days first because he wasn't really himself. And I mean, you guys know Kanan, he is all over the place and he was just kind of very subdued and just sleepy. And so they could tell he wasn't really back to himself yet. And so I just wonder if there are similar recommendations for introducing them back into not exercise, but just their normal day that also could be very hard for them after a situation of like rhabdo or something like that that's not exercise related.
Sure. So, you know, there are different stressors on the body that can put you into this state where your muscles are trying to do fatty acid oxidation that they can't do. Temperature, illness, fasting, exercise, all of those things, you know, are stressors on the body in that way and can tip you over the edge into this state where your muscles are breaking down. So I think you make a great point, which is that, you know, we talk a lot about exercise-induced rhabdo. I think the reason that we talk a lot about that is that it's sort of the most modifiable and there's the most opportunity to sort of use trial and error and use different fueling strategies and exercise strategies, whereas some of the things that you're talking about, while they are modifiable, they're just a little bit less, you know, those are sort of things that happen to you. So it's, you know, it's important to have contingency plans when you're in that scenario, but it's a lot more individualistic in terms of you working with your doctor as opposed to, you know, me as a provider giving an adult or a teen a set of tools that they can kind of work with and tinker with. So I think that's my explanation for why you heard the content that you did over the last couple of days. I think you're absolutely right that, you know, there's always going to be some recovery time. But I think that's also going to be pretty individualistic in terms of what that's going to look like, in terms of how long does it take to get back to 100%, and what are the accommodations that are going to be needed over that, you know, medium term time frame to get back there. But yeah, I've cared for kids with you know, similar stories, and certainly that resonates with me as being a real experience and something that needs to be accommodated for.
Yeah, thank you. So even like with the sports is very, like you said, very specific things you can do. Even in a general sense, would it be anytime your kiddo's in a rhabdo or has some sort of issue despite the cause, you know, for a week after, increasing calories to this amount or increasing their MCT to this, you know, like, I mean, any like general sense of just post, you know, episode, despite, you know, the cause, just some general things to be thinking about.
I don't know that I would necessarily right after that episode jump to consistent elevated calories, et cetera. I mean, I think at that point, their bodies are recovering, but it may not necessarily be that you're in catabolism. You reversed that catabolic process, and now you're healing. So I don't know that I would necessarily jump to, you needed, you know, for a week after sick day type of protocol. I like the idea of going back in slowly, and the shorter school day is probably really helpful.
Okay. Second question. Sorry, this should be really easy. Distribution of like formula, Lipostart, whatever they're drinking. So Kanan's on 18 ounces a day. We're having trouble at school, right? Getting it all down. Are you guys against, I mean, does it need to be this equally distributed throughout the day? Like we've kind of done kind of just on our own, like 4 ounces in the morning, 4 ounces at, you know, breakfast and an early snack. And then, right. Or could we do like hey, drink a whole bunch before school and we'll drink the rest after school, you know, and you'll just do Gatorade and MCT throughout. They're like, are you guys opposed to that? Is that like a bad idea? I'm just trying to figure out how to get it all down and not have the teachers like, you know, talking to them every week about him getting it in.
Well, I'll let Sommer weigh in too, but I guess the question is why, you know, what's the Lipostart? Is that your source of MCT and protein and calories, or are there other sources of MCT? So MCT works and it peaks and it declines every 4 hours. So taking it all at once and then not having some for 8 hours is not necessarily ideal if that's what the Lipostart is for. I'm not opposed to doing, you know, more Lipostart in the morning and then solid food snacks at school and then more Lipostart after school. So I think that the question is, what's the purpose of the Lipostart?
Yeah, and he has MCT oil throughout the day as well. So he has that multiple times at school in his Gatorade and like one at lunch.
Okay.
And so there are other ways that he's getting the MCT in throughout the day.
Right.
Yeah, I would just add, you know, maybe working with your clinician, your team, dietitian, seeing if there's ways that it can be modified somewhat to bring the volume down, you know, as he gets older, make it more of a modular system, kind of hitting those things that he needs, as long as, you know, if it's the Lipostart is providing additional calories, or again, as Dr. Gillingham said, you know, kind of what that Lipostart is for,
Right.
Can that be modified to a more modular system in a lower volume and still spread through the day, but just not so much volume? Or, you know, doing some in the morning. And again, just like Dr. Gillingham said, you know, a little bit right after school and then a little bit more kind of distributed through the evening. But I agree that fight is real. And that's an additional stressor on families of drink formula, you know, and that's ends up becoming, I think, you know, someone had mentioned that relationship with the parent often becomes all about the formula or all about the food. And if there's ways to modify that volume, to take that stress off of you, that stress off of him, and even that stress off the relationship around that constant push for the formula. So you know, I would encourage you to work with your team and your dietitian to see if there's ways to modify it some way.
And I think as a more general point, there's always going to be a tension. There's always going to be trade-offs between what's ideal and what's practical. And, you know, that's where that kind of individual relationship comes in with the team that you're working with, to say like, okay, this is the ideal, but here's what's practical. So like, you as a clinician, what are your top priorities in terms of things that we can really focus on? And what are some other things that are lower priorities that, you know, while not ideal, we have practical considerations to just be a kid in the world and be in school, you know?
My question is a nutrition question. We take a food as medicine approach, a big holistic approach as much as we possibly can. And I'm wondering about fiber and the postbiotic production of short chain fatty acids that our body makes in the small intestine. Short chain fatty acids possibly being very important to this group, especially the functioning of the heart and the brain and other things. I'm wondering if you guys could expand on that or offer any knowledge and what that might mean to this group.
That's a great approach. I love that. Food is medicine. And I can say that, you know, I think in the general nutrition world, there's a lot more research on fibers and short chain fatty acids, probiotics. I think it's an exploding world in the nutrition science field. I can honestly say I don't know that there's been any. Well, I can think of a couple of research papers on probiotics in FAODs. So I like the concept of food as medicine and increasing whole foods, healthy foods, as part of a regular, really well-balanced diet. And definitely those whole foods have fibers and those are going to be beneficial, and the short chain fatty acids would also be beneficial. In fact, short chain fatty acids are kind of ketones, right? So we're going back to our ketone discussion that we started off in the beginning. But I think I can only think about one paper that's actually been research done in FAOD. So I think it's really an area that's been focused predominantly in the general nutrition literature. Would you agree? Yeah.
And just to mention this is not at all relevant to my knowledge to fatty acid oxidation disorders, but other inherited metabolic diseases. There are clinical trials of genetically modified probiotics that are specifically modified in their metabolism to sort of complement the metabolic deficiencies for an individual with an inherited metabolic disease. So, you know, that's something that people are thinking about more broadly in terms of treatment of metabolic disorders.
Good point.
I have a question. It's about infection and about how your body does with that. So Christopher, and I know several other FAOD families have shared that this is a thing. When he starts to get an infection, typically his temperature decreases like 97.1, 97, like significantly. And he feels hot to the touch, but it's like way low. And then within probably like 12 hours or so, then it spikes. And so it's the joke in our house, like, oh, your body can't figure out how to make a fever. So it just, you know, do you know like what that's about? Have you heard of that happening in is there a physiological reason that could potentially be going on?
Yeah, so that's a great question. So your body temperature does actually vary throughout the day, right? So it depends on the time of day that he actually was testing it. I mean, if it goes down to 97 something, 97.5, I mean, that's not for normal. There's a range, right? So it may be just kind of normal variation of what he's experiencing throughout the day. And then usually with viruses in general, fevers tend to happen in the evening. And even when the kids, you know, feel like they're recovering and the next day they're great, you know, during the day, they can be active the entire day. And then all of a sudden, you know, in the evening, they start to feel bad again and the fever pops back again. So, you know, what he's experiencing may be kind of his normal fluctuations, his diurnal variation in temperature, and he's feeling miserable because it's building up to something, and then he actually has his spike in temperature.
So what if he normally runs, like he doesn't normally dip down? Like, is there any information about that? Like if normally he's like a pretty solid 98.5 kind of kid, like, but it only happens prior to infection.
Well, I bet if you measured often enough, he's not a solid 98.5. That's kind of what I'm saying, is that, it may be almost like a sampling bias, right? That when he starts to feel miserable, you catch him at that time of the day, and he hasn't spiked at that point, but he's at a time in the day when he actually has kind of this dip or this kind of normal oscillation that we all have, essentially. So if if his temperature dropped like super, super low, then you're thinking about other things. You're thinking about like either autonomic instability or sepsis, because sepsis, one of the end results of sepsis can actually be a major temperature instability where you actually drop your temperature.
So, I don't disbelieve you, because we learn a lot from parents. I don't really, other than like where you're going into sepsis from usually bacterial types of infections, I don't have an explanation for it, but it might be interesting to keep a temperature chart.
I'm totally speculating here, but part of your body temperature just comes from your physical activity. So it's just the contraction of your muscles, you're moving around. That's a substantial amount of what generates your endogenous temperature. So it's at least conceivable to me that in the course of an illness, the first thing that happens is a kind of subconscious decrease in physical activity that you could be picking up on that way, prior to the other things that then kick in as part of the inflammatory response that give you a fever.
That's a good scientific potential explanation. But I learned a long time ago, when you don't listen to parents, you get in trouble.
Are there any other questions? Yes.
So we know stressors cause rhabdo. Are there any insights y'all have to maybe chemical stressors within the body, like adrenaline or hormones, that are just being the sole cause of rhabdomyolysis episodes?
I don't know that we ever looked. I mean, you would think that adrenaline or epinephrine would be driving you to be trying to pull sugar out and turn your metabolism on. So it could be, but I don't, those things are actually really hard to measure.
Stumped us. Yeah, I've just had some episodes where like there's no explanation except maybe that I'm on my cycle or something, or got too excited. So
Well,
it's
adrenaline or epinephrine is part of that fight or flight reaction, and you're certainly would be trying to pull glycogen out of your muscles and shoot them a burst of energy to fight whatever was going to be coming at you. So you could, sort of think that could do something, but I don't. That's just a teleological explanation in my head. I have no idea if that's real. It's really hard to measure neurotransmitters. What's in your blood is just really hard to measure.
Hello. I have a question about my son has really low hemoglobin, and his hematologist wants to do more studies, thinking that TFP is the cause of this because iron supplements are not helping. They think that his cells are just weaker and it's having trouble with the hemoglobin. So have you ever heard of that happening, or any insight on that?
It's hard to comment without knowing more about what the blood slide looks like. It sounds like it's small red cells if they're looking at iron. And there are other causes of small red cell anemia. Anemia of chronic disease, thalassemia, which has roots in either Asian or Mediterranean populations. So it's really hard to know without knowing what that blood smear looks like.
Well, they've done like every test in the books. It's been going on for like a year now, and they can't find any other explanation, if that gives you any help at all.
Yeah, I would also say that, if we're using diets that are kind of non-physiological or, pretty far from a sort of standard nutritional regimen, it's incumbent on us to really carefully look at the nutritional outcomes that are resulting from diets that deviate pretty significantly from kind of typical intake. So that not just iron, but B12 and folate and other things can play into that as well.
I'm not aware of it being a common problem in TFP. Anyone else?
No.
Yeah, so I think it's probably reasonable to look for another explanation.
I'm kind of piggybacking off Alex's questions. Has there been any research about in women in FAODs and their cycles and hormonal changes? I know that in online groups and with my daughter definitely become more symptomatic right before her cycle starts and those kinds of things. She's not here, so I can't embarrass her, but I just wondered if there's any clinical studies or data about that. And also how to treat other than just extra rest and nutrition.
Yeah, it's been observed. I mean, I see it a lot and it gets reported to me from patients a lot, but I can't think of an individual manuscript or publication that actually looks at it. It seems to be something that we all kind of generally accept as true. But it doesn't seem like something that's been systematically studied. I agree with that.
I did read an article once that said women were slightly catabolic right around their menses.
Yeah.
And this is not just an FAOD thing. It happens in our other patients with metabolic disorders of fasting as well.
The articles that I've gotten to read haven't defined if the patients were in their cycle or not, but generally some of the case studies of patients with FAODs who experienced rhabdo and who were identified later in life, like teen and 20 years of age, they were women and they completed exercise. They just didn't go into that measurement, and it just seemed like they had repeat series of stressors and exposures that eventually led to that diagnosis. But it would be interesting to document and measure.
This question came in from the basket. Has anyone looked at overall low IG or IgG subclass deficiencies or poor antibody response in FAOD patients? And what are your thoughts about IG replacement therapies in FAODs?
Peter left. Oh, Dr. McGuire just left.
And I know Dr. McGuire just left.
That's the guy to answer.
Go for it,
so
Dr. Larson.
I would be relying on my colleagues in immunology to measure the IgGs and think about the risks and benefits of IgG treatment in the setting of particular IgG levels. Those studies are getting more and more sophisticated in terms of identifying subclasses, and IVIG treatment is no longer just IVIG, so there's subcutaneous immunoglobulins. So that can kind of change the risk benefit calculus, given that the administration is something that can be done at home now as opposed to in an infusion center. But there's definitely risks associated with that, and there's definitely major financial implications of implementing that therapy. So I think it would have to be a pretty sophisticated decision-making process that, at least for me, would involve my colleagues in immunology.
So this one's also about pain. When thinking about overall pain management, are there alternatives to Tylenol and ibuprofen that could be helpful, like CBD? I'm not going to get this word correct. Kratom, Kratom, or black cumin seed oil, only if you find a third-party regulation.
I don't know the answer to that.
Yeah, I can't comment on those substances specifically. I will say that, we have really effective medications for treating acute pain, but chronic pain is a completely different phenomenon than acute pain. Typically pharmaceutical approaches are less effective, and chronic pain is more about trying to identify the root cause and kind of changing the underlying circumstances as opposed to treating the symptom. That's a pretty general statement. Obviously, there are a million different individual circumstances that people are in. But as a general approach to sort of acute pain versus chronic pain, that would be my thought process.
And while I'm walking up and giving the mic, is there a preference between Tylenol or ibuprofen if you think your kiddo is going into rhabdo?
Yeah, I mean, ibuprofen would be concerning for me, given the risk to the kidneys, the combined insult of NSAIDs, which reduce renal perfusion, in addition to myoglobin and other toxic substances from the muscles. That combination has been shown to increase the risk of kidney injury. So that would be concerning. That said, we do have some patients with fatty acid oxidation disorders that have some liver manifestations, in which case Tylenol would be problematic. So it would be a kind of an individual decision based on which of those risks is the largest and what the severity of the pain is.
Obviously, rhabdo is a big concern for this community. What are the prospects of an in-home CPK test being available?
An in-home CPK meter?
A meter, yes.
I don't know.
I know Jerry Vockley is working on it. I don't
Yeah.
have any insights other than that.
You mentioned that unofficially you've noticed that, females that have FAODs just during their cycle. What about the boys when they start hitting puberty? Like, what do you see a consistency like the girls or not as much? Does that make sense?
Yeah, I mean, there are so many factors there, right? So, across almost all of pediatrics, problems arise in adolescence. So this is true, like they've studied patients that are transplant recipients. So, the likelihood of organ rejection goes way up in adolescence as compared to being a preteen or a child. It's really hard to be a teenager, having been one myself. It's, there's so many things going on in terms of handing over responsibility for different aspects of care, so many aspects of the peer pressure that you're exposed to, and exploring new opportunities and new environments. And it's really hard to tease apart like which of these things are physiological and hormonal versus, kind of circumstantial and more social. So I don't know if we'll ever know, but certainly that phenomenon is absolutely, rings true to those of us in clinical care.
Yeah, there are some things that seem to get worse with puberty, some that seem to get better. But many years ago, my nephew came to spend a week at spring break with me, and I went grocery shopping before he came, thinking it would last a week, and it lasted 2 days. So the amount of food that they can require can be prodigious at age.
Yeah, just because it came up in one of the previous panels. What really are the major concerns or things that people need to think about with FAODs with childbearing? It's always interesting to me because when I bring it up with my metabolism or genetic specialists, they seem to take Dr. Vockley's approach, which is it's possible, we'll figure it out. You need to work with your medical team. But I always find it interesting. The cardiologists seem very concerned. Every time I've ever even kind of diverge into the conversation, they get very alarmed about FAODs in pregnancy. So I just, from your all's perspective, I don't know what your thoughts are.
Yeah, I mean, so pregnancy is a time of a lot of major physiologic changes. So I've had patients with metabolic disorders that have, sort of thought through the risks and benefits, felt very strongly about pursuing pregnancy, gone forward with it. It's been an open discussion. And I don't have any great insights other than a direct discussion between the metabolic provider and the cardiologist can often be really helpful, and the MFM provider. So usually there would be like a high risk OB or MFM involved, and just having that discussion, face to face or real time discussion between those specialists, and talking through what would increased monitoring look like, what kind of contingency plans can we have in place, if we start to identify an arrhythmia or cardiomyopathy, like what are the interventions that we might turn to at that point, and just kind of doing some contingency planning ahead of time. I think it helps everyone to feel more confident, heading into that.
The accumulated long chain acylcarnitines can be cardiotoxic. So I understand that. A couple of years ago, we published the data. I think Dr. Vockley in his talk talked about the Region 4 IBMIS database, where they had some NIH funding for 10 years to follow up, and 50% of the cardiomyopathy cases happened in early childhood, but the other 50% happened after age 10, which was a little bit of a surprise to me. I hadn't seen a lot of new cardiomyopathy in older patients. I'd seen mostly in neonates. There's a lot of vomiting that goes on in pregnancy. So I think it also depends a little bit on, how stable your own care is and your own diseases, and how much residual enzyme activity there is. I think it's a tough decision. I am not aware of a long chain FAOD mother having an affected baby. Has anyone ever done that? That would worry me a lot. Just in terms of neither the mother nor the baby being able then to manage the stress.
So my question is regarding rhabdo and the effects of the rhabdo having nerve damage. Has there been any studies regarding like the use of lion's mane or some of the other, mushroom substances that help regenerate neural pathways? Has that been looked at all?
Yeah, I would say the rhabdo itself is not directly causing peripheral neuropathy, but they can coexist in the scenario of kind of worsening long chain fatty acid oxidation disorders. You can certainly see progression of both of those concurrently. The muscles regenerate themselves pretty quickly. The nerves regenerate themselves slowly. So they're on very different time frames in terms of the timing of recovery. Peripheral nerves do recover if you can alter the circumstances that are causing progression of peripheral neuropathy. You can get some recovery, but it is on the scale of months to years as opposed to days to weeks, the way that rhabdo is. I don't know if I'm not a peripheral neuropathy specialist. I don't know exactly what the state of the art is in terms of altering the timing of peripheral nerve regeneration. Thanks.
Dr. Gillingham, you are in the middle of your eyes study, and I know it's not completed yet, but can you share if you're seeing anything promising or
Yes, I'm happy to share. We are in the middle of our natural history of LCHAD retinopathy study, and we're collecting a lot of really amazing data. So thank you to all of those of you who are in the audience and online who are participating. It's been hugely helpful. So in the initial analysis that we're working on right now, we're looking at participants who were diagnosed symptomatically versus newborn screening. And we're seeing a different trajectory of over time in patients who were picked up by newborn screening, really pointing to the benefit of early detection and early treatment for LCHAD and TFP. So that's exciting. And I hope that will be a message that we can send out and encourage maybe countries who don't do newborn screening, the importance of it. The other thing we're looking at is genotype relationships. It does seem to be, the retinopathy seems to be more advanced, or should I say a little bit more progressed in patients with the common LCHAD mutation, the G1528C, and even more so in people who have 2 copies of the common mutation. So it really seems to be tied to the common mutation. And we're trying to look at a little bit deeper as to why that might be. So we are seeing some genotype relationships and some relationships to early treatment, diagnosis and treatment. On the basic science side of our lab, we're working on a retinal gene therapy approach. So we have an LCHAD mouse, and we're trying a LCHAD retinal gene therapy. We hope to have the results of how those mice did in August. We're going to be looking at the results, so it's coming up really soon. So we're working on ways that we could do a gene addition, so putting the eye in, if that would preserve vision over time in the mouse model. Obviously, there's a lot of steps to go through before we'd ever get to that type of approach in humans, but we're working on both sides, both defining the natural history as well as on the basic science side, what a treatment option might look like.
I wanted to know if you guys have a general, I guess, set of guidelines that you use for initial birth of a baby that you're not sure if they have an FAOD yet. I only asked that because with my first son, there, I didn't know a lot. So there are a lot of things that in learning from this community and other parents after I said, oh, I wish I would have asked for that. I didn't know that it was possible that I could maybe still do this or do that. And so I'm wondering now that we're talking through our plan for this baby, if there are things that I could ask for that I am thinking, but maybe not knowing for sure if it's something that I could bring to my team, because they've kind of laid down this pretty aggressive, plan for once I deliver. And so I just wanted to know from you guys, are there general rules of thumb that you're like, well, yeah, if maybe the first baby has a severe phenotype, then maybe, the mom can't breast, I don't know. You know what I'm saying? Are there I'm trying to figure out where I can push back / ask questions, and where I should just say, okay, yep, okay, we'll do it. That's fine.
Are you asking about management before the baby's tests come back?
Yeah, correct.
Well, an option, if your insurance company will pay for it, is to have prenatal diagnosis. And then if you know what both gene variants are in your affected child, then the fetus can be tested for those, and then you'll know. Otherwise, we often call the state to get the newborn screen expedited. And depending on the disorder, sometimes in VLCAD, the acylcarnitines tend to trend down after delivery. So that newborn screen might be abnormal at 24 hours, but when that test comes back at 7 days and you retest the baby, it might now look normal, which is why we work up kids with abnormal newborn screens for VLCAD. And people have tried to write protocols for ratios and things to tell you whether when it normalizes, you need to worry about it. But those are some of the things that you can do. If you don't have a prenatal diagnosis, you certainly can, use monitoring, use pumping. If you don't have enough breast milk, supplementing with formula. What other ideas do you have?
Depending on where you live, whether you have a local biochemical genetics lab, we could have an acylcarnitine profile done the same day. So that may be an option depending on where you live and what the hospital can do. I think so. If you don't know whether the new baby is affected, the presumption would be that biochemically, if the new baby were affected, which would be a 25% chance, then the biochemistry and the clinical severity, while not identical, would be likely very similar to the older child. And so you could make some medical decisions accordingly in terms of degree of expected residual enzyme activity and what exactly the management would be in that scenario based on the family history that you already have.
Because I think with my son, I mean, he came via emergency C-section because he was already in distress before, my due date. And then he got here, he was having issues with his blood sugar, his temperature, all of those things, right? So I'm kind of thinking, could we look at those things at birth and, wait for the test? I mean, and I think one thing too, like colostrum, for instance, I read that that's a lot less fatty. And I don't know if this is right. Everything on the internet is not true. But I read that colostrum is a lot less fatty than breast milk. So I'm thinking if that's what they're going to be drinking anyway, maybe we can do that for the first few days and then, you know what I mean? But I just, you often look at your doctors as the expert and you don't know where you can have a say or ask, and so I'm just trying to figure that out.
Can anybody fact check that about the colostrum having less fat? Any thoughts?
I know it's high in
No.
protein.
But it sounds like a good question then to ask your doctor for sure.
It does. Ask your doctor.
Yeah.
Yeah, I mean, so often we might take an approach of, if you can get an acyl carnitine profile done and get results within a couple hours, then you can probably answer the question on a time frame that would allow you to pretty definitively either manage the disease or know that it's not present. If it's going to be a little bit of a wait, then we would be checking glucose pretty closely. Probably, given that there's a 75% chance that the child wouldn't have the enzyme deficiency, then depending on the circumstances, it might be reasonable to initiate breastfeeding, monitoring blood glucose very closely, giving supplemental formula after breastfeeds to make sure that the baby's calorically supported while you're waiting for information. I think those might be reasonable. I don't know the specifics of the circumstance, but that might be the discussion to have.
Any last question? Thank you so much for being willing to answer all of our difficult questions, but really important questions. And thank you so much for coming and sharing with us. We are going to move into closing and see some pictures from the weekend.